Hello, everyone. I hope you had a restful weekend and that this week is off to a great start. Now, we stopped our conversation here last time. As we go through this chapter, I'm going to go at a pace that allows you to follow me. Very importantly, I want you to pay a particular attention how each of the diseases we are going to cover ties up with what we saw in basic microbiology. We talked about the microorganism, we talked about bacteria, viruses. This is basically what we are going to cover in here, right? We're going to talk about, the different types of bacteria and the way they make us sick, the tissue damages they cause, what do they produce that actually cause these tissue damages? Do we have a way to fight, to control the microorganism? Do we have a way to prevent the infection using the knowledge that we got from how our body responds to infectious particle? So, without further ado, let's dive into our first disease here. The first disease we're going to address is diphtheria. Diphtheria is caused by an organism called Corynebacterium diphtheria. That Corynebacterium diphtheria is able to enter the system by inhalation. So by breathing it in, it's going to come and establish, it's going to colonize the throat, the nose, and the nasal cavity. It's going to release toxins that end up forming on the surface of mucus, something that is like a membrane. It's like a glare that is actually going to spread through the mucous membrane. Eventually, it's going to release a number of toxins that can actually cause deep tissue damages. And when I talk about deep tissue damages, I mean the nervous system and the muscular system, because it's going to cause, if not treated properly, paralysis. And paralysis, it's basically a lack of communication between the nervous system and the muscular system. There is no more stimulation of the muscles by the muscular system. In some instances, and these are complications, obviously, we're going to have damages of the heart muscle, and eventually the muscle is not going to pump properly. The valves can be leaky, the kidney can be affected, and obviously, if there is paralysis, that means that the nervous tissue is affected, so the nerves can be affected. Eventually, we're going to have a membrane that may become loose and be able to move around. And as it moves around, eventually it can clutter the airways. And if it clutters the airways, that is going to lead to more complication. Eventually, this bacteria can exit the body through the respiratory secretions. Now, when it comes to the nursing segment of it, you're going to ask, well, what are the signs? What are the symptoms? So typically, we're going to have sore throat, fever, fatigue, okay? And the membranes that are going to form on the mucous membranes, right? I told you about that. And typically on tonsils, the throat, and the nose, okay? The incubation period is going to last about 2 to 6 days before you can actually feel the real effects of the presence of Corynebacterium diphtheria. That Corynebacterium diphtheria is going to produce a toxin That toxin, it's the AB toxin. Now, remember we talked about the AB toxin, right? Where we have two subunits. One unit that is some kind of carrier. The other unit is the toxic part of the toxin. So the carrier is going to allow the toxic part to be carried inside of the cell, the eukaryotic cell, and once inside, the toxin is going to do its job, which is to damage the tissue. The pathogenesis, it's that of exotoxins, right? And this is going to happen in the upper respiratory tract. Now, if we say exotoxin, we also mean that this toxin is a protein, right? That toxin can be released, can travel away from where the bacterium is located at, right? Eventually, the toxin is going to cause cells to die. How does it cause cells to die? By interfering with protein synthesis. That is a major issue, right? If it's interfere with protein synthesis, that means that enzymes are not going to be produced. And if enzymes are not going to be produced, this is a major problem for the function of your tissues, right? For the function of your cells. That explains why you can experience kidney failure, you can experience heart failure, right? And other tissue damages. Now, in terms of epidemiology, one is going to be infected by breathing in air that contains particles, so the droplets that contain bacteria. And those droplets are, once one breathes them, they're going to establish and multiply, and that can become a problem, right? In terms of treatment, we can actually treat the disease with an antitoxin, which is going to interfere with the activity of the toxin to neutralize the toxin. We can obviously use antibiotics, including erythromycin, right? That is actually going to destroy the microorganism. And eventually, because we are dealing with an exotoxin, that is kind of a good news. Why? Because this is a protein. And a protein is typically immunogenic. You can anticipate that. Because this is a proteic toxin, well, it can be weakened and in the form of a toxoid, right? And this also means that we can develop a vaccine, right? And that vaccine is provided in the form of DTaP that is given to children at 6 weeks, 4 months, 6 months, 18 weeks, and 4 and 6 years, right? And then after that, the child is going to, the person is going to receive a boost every 10 years. How about pink eye, earache, and sinus infections? Well, these are common diseases that are caused by both bacteria and viruses. Most of the time, though, we're going to have Haemophilus influenza, which is a gram-negative bacterium. And if you say gram-negative bacterium, you're going to, based on basic microbiology, know that this organism has a thin peptidoglycan, has an outer membrane, which means that it does not rely too much on the peptidoglycan. What this means also is that, well, lysozymes are not going to have a strong effect on a gram-negative, right? Because they have an outer membrane. I'm just saying this so you can start anticipating, right, of what could happen. And beside Haemophilus influenza, you have Streptococcus pneumonia. Streptococcus pneumonia is a gram-positive bacterium, right? That is a coccus, so spherical. It's encapsulated. Now that encapsulation is going to be another layer to the thick peptidoglycan. I want you to think about that because that other layer is going to allow this microorganism to actually get away from our immune system, right? But let me close the parenthesis. So here we're going to talk about conjunctivitis, right? Otitis media, and sinusitis. Now, all these three infections can be caused by Haemophilus influenza and or Streptococcus pneumonia, right? Now, for conjunctivitis, we're going to see tears developing, redness in the eye. That's why it's called pink eye, right? Swollen eyelid, sensitivity to bright light, and pus that develops. And that pus that develops, it's right here. For instance, you can see the pus right here that develops. Okay. Otitis media, it's going to be a very painful, right? What we call earache, very annoying. Kids are going to cry a lot because of that. So not a very funny situation for kids. Sinusitis is going to cause facial pain, pressure, headache, and other symptoms. Now, I did tell you that Haemophilus influenza is a gram negative. If Haemophilus influenza is gram negative, you're going to expect this guy to resist destruction by lysozymes. And we know that the lysozymes digest the peptidoglycan. And if this guy does not rely too much on its peptidoglycan, it has its outer membrane, you understand that the lysozymes are not going to be very helpful here, right? The organisms that actually causes pink eye can also break down mucin, okay? They can produce proteases, collagenase, and coagulases. Now, all these enzymes, proteases, collagenases, and coagulase are going to break down proteins. Proteases are going to break down proteins. Collagenases are going to break down collagen, which is part of the connective tissues, right? And the coagulases are going to cause coagulation, right? So break actually down proteins, destroy cells that are going to actually gather in the form of a pus. That is kind of a little nasty. The ear infection that leads to earache is going to be caused by the accumulation of pus here, multiplication, obviously, of one of these organisms, Haemophilus influenza, and also what did we call it? Sorry, I'm drawing a blank. Let me go back. Streptococcus pneumonia, they can both cause this disease that is going to be an inflammation of the inner ear with the affection of the eustachian tube right here that is going to be cluttered, right? and the formation of pus here, which is a breakdown of white blood cells. Now, what is the ecological of these diseases? Well, this infectious agent, first and foremost, they are very common in the environment. There is a carrier rate of 80% that tells you that this infectious agent are very much prevalent. However, our system knows how to prevent this infection so that they don't actually be as often as this organism occur in our environment. What else do I need you to remember here? Oh, one thing that you may want to know is that the development of otitis media is often exacerbated by the use of pacifier in children, right? That's why it is always encouraged that children stop the use of pacifier at a relatively early age so they don't experience this pressure that ultimately is going to cause frequent ear infections. Now you understand that in terms of anatomy, the eyes, the ear, and the nose are connected, and because they are connected, one infection can lead to another infection. In other words, having pink eye can lead to sinusitis, can lead to otitis media. They all communicate, which is actually a problem. And many children actually, once they have a pink eye, they tend to also have otitis media. And the more often they have otitis media, the more often they're going to have pink eye, etc., which is actually which causes us to understand better why why we have the frequency of infections we do see in our environment. Fortunately, antibiotics are going to be great at preventing this. I mean, not preventing, but fighting the infection, right? They're going to be, this is a chronic disease, right? Pink eye, and not a chronic disease, I'm sorry, an acute disease, pink eye, otitis media. These are acute diseases, so they come fast, they also go fast, provided that you take the proper treatment, right? So antibiotics are going to be generally very effective if we use them properly. And that's why we have to make sure that the infection is actually a bacterial infection, not a viral infection, right? Then our next stop is going to be the common cold. The common cold is caused by the rhinoviruses. These rhinoviruses occur in our environment at a huge rate, and because it occurs in our environment at huge rate, most of the time people are going to be infected many times, even in the course of a year, right? And the common cold in general causes what? Malaise, sore throat, runny nose, cough, hoarseness, hoarseness, okay, nasal congestion. All of that can actually be caused by the rhinoviruses. And what we typically also notice is that the rhinoviruses, while they are annoying, while they can cause runny nose on a regular basis, they cannot kill you, right? So that is kind of a good news because in spite of the frequency at which it can happen among us, it's not actually something that can be fatal. Even when you are immunodepressed, we don't know of instances when immunodepressed people died because of the common cold. So I told you that the causative agent is a group of viruses called the rhinoviruses. They are non-enveloped viruses. These viruses are RNA viruses, right? They are RNA viruses, meaning that their genome, it's RNA. So this slide is just to actually provide you some summary of diseases, of the common cold, the sign, the symptoms, the incubation period, the causative agent, the pathogenesis, epidemiology, and the treatment. Now, by the way, what is the treatment for common cold? Well, you are going to know that, well, there is no real treatment, right? There is no real treatment. Get some tea, some warm beverages. In general, you are going to treat the symptoms, not, you don't really inactivate the virus itself. You're going to treat the symptoms. How do you avoid that? Wash your hands on a regular basis, right? Wash your hands. Make sure that you use hand sanitizers, right? They can help a lot. And because let me come back here. No, I'm not. So, how about the lower respiratory system? The lower respiratory system, the trachea, the bronchi, the bronchioles, the lung alveoli, not only this, well, no, let me digress. The infection of lower respiratory tract is going to be less common, much less common than infections of upper respiratory tract. It kind of makes sense because in the upper respiratory tract, in the nose, for instance, you have hair. That hair is going to block a lot of particles that are in the air that we breathe, right? What else are we going to have? We're going to have cilia. The cilia that are going to be on the pseudostratified columnar epithelium along the trachea is actually going to trap a lot of the particles that are in the air that we breathe, so that this cilia are going to vibrate, push the potential infectious particle toward the throat, then we're going to swallow, and in the stomach, this potential infectious particle are going to be destroyed. So most of the time, we don't have lower respiratory tract infection. However, when we do, that's pretty much a bad news. That's pretty much a bad news because our lungs can start being really affected. Our airways can start getting narrow. And if our lungs are affected, airways narrowed, lungs filled with fluid, what happens is that the surface of exchange is going to decrease. So when we breathe in, we don't uptake enough oxygen anymore. And not uptaking enough oxygen is going to be less ATP in the body. And less ATP in the body means less energy to support our activity, right? Whether it is metabolic, physical, and so on. Okay? So, the body actually is going to try to do anything it takes to prevent this lower respiratory tract infection. However, when that happens, what happens and what are the type of infections we can get there? We can get pneumonia, which is a bad news, right? Pneumonia, it's basically an inflammation of the lungs. We can get bronchitis, right? Which is an inflammation of the bronchi, right? We can get bronchiolitis, right? Which is an inflammation of the bronchioli, right? So these infections are pretty bad, and when not treated properly, they can lead to death, right? We have some examples of those infections. For instance, whooping cough, bad news. Tuberculosis, another bad news. Legionnaire disease, another bad news. They are all bad news. Anytime you have an infection of the lower respiratory tract, it's definitely a bad news. Okay? We have some agents that can cause infections of lower respiratory tract. We have Pseudomonas pneumonia. Pseudomonas pneumonia can actually cause pneumonia that can be fatal, right? So we have some streptococci here, right? And we have some white blood cells here that can actually engulf the streptococci. And the white blood cell that we show here is the neutrophil that is able to engulf this bacteria and destroy them. Oops. So here we have an X-ray with a normal X-ray here where we see how the lungs here are cleared. So that's a healthy lung. While here we have one lung here that is filled with fluid, with some solid particles, which actually cause you to see what you see here. So this is the bad news. This patient has this left lung that is severely affected, while the right lung is in better health. Okay, so in terms of some infectious agent here, we have three kinds here. We have pneumococcal pneumonia, Klebsiella pneumonia, and Mycoplasma pneumonia. I want you to review these three infectious agents, what they do, can they be treated, how do you prevent this, and basically review the whole slide. So let's start with pneumococcal pneumonia. The signs and symptoms are going to include cough, fever, chills, some rust-colored sputum. One can actually spute blood because of breakdown of tissues, shortness of breath, and chest pain. This is an acute disease that is characterized by an incubation period of 1 to 3 days, okay, caused by pneumococcus pneumonia, right? These are cocci. What else do you need to know? Basically, you breathe the infectious particle in, then it's going to colonize the lower respiratory tract, including the lung alveoli. These lung alveoli are going to be filled with fluid. We're going to have an inflammation of the lungs, and eventually this can lead into poor exchange in the gases. That's why there is shortness of breath. Okay, shortness of breath. Now, who is at risk of developing this infection? Well, some lifestyle can make you prone to developing this kind of infection. For instance, when we drink too much alcohol, we become prone to this type of infection. Using drugs also can cause this type of, can favor the development of this type of infection. And also a pre-infection with a virus that weakens your immune system can also make you vulnerable to this kind of infection. Smoking can be smoking can favor the development of this kind of infection. Now, to treat this infection, because this is streptococcus, any beta-lactam is actually a good fit here. Okay, amoxicillin, penicillin, erythromycin, right? These are drugs that can be used to actually treat this disease. Now, I have to say that streptococcus pneumonia, pneumococcus, yeah, pneumococcus, no, I'm sorry, streptococcus pneumonia is actually one bacterium that can have a capsule. And that capsule is actually a factor of virulence. It allows it to actually escape the system. Fortunately, we do have vaccines, right? Pneumococcal vaccine that is used to actually prevent this infection. Now, how about Klebsiella pneumonia? Klebsiella pneumonia is going to cause chills, fever, cough, chest pain, and mucoid sputum. Also, an acute infection with an incubation period that is 1 to 3 days. You get it by breathing the infectious particle that is going to come and multiply. Unfortunately, this organism can often develop resistance to antimicrobials, right? Which is actually a bad news. Klebsiella and other gram-negative organisms can actually be associated with leaky valves. Okay, so from that perspective, they are not a good news. They can cause complications at the level of the heart. There is no vaccine, unfortunately, but there are some antimicrobials that can be used to treat this disease. So how about mycoplasma? Mycoplasma, you know that mycoplasma does not have a peptidoglycan. Because it does not have a peptidoglycan, you cannot use beta-lactams to actually try to control this infection. You have to use other antimicrobials, including erythromycin. Okay, there is no vaccine. There is no vaccine to prevent mycoplasmal pneumonia. All right, so here we have a slimy form of the bacteria that are causing this infection, and you have some rod-shaped guys here that are the causative of this lower respiratory infections. Now, how about pertussis? Pertussis, it's actually caused by Bordetella pertussis. Bordetella pertussis is a gram-negative bacterium. If we say gram-negative bacterium, you assume that, well, the beta-lactams are not going to be the antimicrobials of choice here. Now, before we dive into all of that, what does it do? It's going to cause runny nose. It's going to cause a spasm. Okay? This spasm are responsible for the whooping cough that you are going to hear when the person is actually coughing, right? The wheezing, there is a wheezing when the person is coughing. The incubation period is about 7 to 21 days. Now, let me tell you up front, adults in general can be carriers, but they are not necessarily able to develop the disease. However, the children are very vulnerable. I want you to remember that, right? I want you to remember that. So Bordetella pertussis produces toxins, right? And these toxins are pretty bad news. These are exotoxins. And because they are exotoxins, they can be used to actually prevent the infection in the in the form of a vaccine, right? So we can develop an acellular vaccine in the D type, right? Diphtheria, tetanus, pertussis, right? And this vaccine is given to children, right? We already saw that um, in the previous chapter. I want you to review that because it's going to be very useful. All right. So, what can we do to prevent this spread of Bordetella pertussis? Well, we have to have a good surveillance system. We have to have immunization system put in place. We do have a vaccine. We do know how to prevent the disease. So it's up to us to really apply the protocol. Now, I have to mention that because sometimes because we have not seen a disease for a long time, we will assume that, well, that disease is not a problem anymore. It does not occur here. It occurs in other places. But guess what? If we stop taking the proper measures, including vaccination, we are going to see outbreak of the disease. In fact, in California in 2010, there was an outbreak of the disease that actually killed at least 10 children. Now, when we say at least 10 children, understand that whatever number is out there, it's underestimated. Just know that it's underestimated because there are many instances where children are going to die, even with the technology that we have. In some places, we won't come up with the right diagnosis, right? So a child can very well can very well die of whooping cough, and without us knowing really that he died of whooping cough or they died of whooping cough. Just know that, okay? So our system is not perfect. We have to understand that, okay? All right. How about tuberculosis? I want to spend a good chunk of time here, and then I'm going to close this window, and we resume next time. So tuberculosis, it's common, even though it's a very old disease. It's more common that we want to actually see it happen, right? Yes, it is not as common as it was at one point in time, but know that tuberculosis is still a common disease, right? In the United States, yes, we do a lot to prevent the spread and the control of it, but in other parts of the world, tuberculosis is still a problem, right? We observe a big decline of the disease for a long time, right? We observe a big decline of the disease for a long time. Then, right here, right here, we saw a peak in the increase in the number of cases. And that it's when we actually dismantled our policies for preventing Mycobacterium tuberculosis spread. Eventually, things were put back in place. Now, also, the incarceration population that we have in the United States is also such that it contributed a lot in the spike. In this increase in the number of cases of tuberculosis. In addition, you have an increase in the population of immunocompromised individual, and specifically those with AIDS, right? We saw an increase in the number of individuals with AIDS, and that increase in the number of individuals with AIDS made them immunocompromised. As consequence of that, we had an increase in the number of cases of tuberculosis that we saw. Now, just so you know, there is an estimate that about 1/3 of the global population is infected with Mycobacterium tuberculosis. Now, out of this 1/3, we don't say that 1/3 of the people are ever going to develop a disease. No, right? But you have about 1/3 of the human population that actually came in contact with Mycobacterium tuberculosis. What becomes of it after? That's another story, right? We have two forms of tuberculosis: the active tuberculosis disease, ATB, and the latent tuberculosis infection. These two forms are not necessarily treated the same manner, right? Because the active form, we do see it, right? You see somebody losing weight, having night fevers, sweating a lot at night, and basically dying progressively. By the way, this is a chronic disease, right? A lot of the diseases that we covered so far were actually acute diseases. But this disease right here, tuberculosis, it's a chronic disease, right? That doesn't develop all of a sudden. It is very progressive and basically kills the person at a low pace. Now, the infection can be treated. It can be treated with the use of antimicrobial drugs, right? The causative agent is Mycobacterium tuberculosis, an airborne pathogen, right? This guy is a slow grower, okay? It produces mycolic acids that cause it to resist a number of antimicrobials, right? What else do you need to know? This guy doesn't actually produce any toxin. Mycobacterium tuberculosis does not produce any toxin. The number of bacteria is what causes the problem. Now, typically, when Mycobacterium tuberculosis gets in our system, it is going to be surrounded by phagocytic cells. And this guy has a mechanism to survive in our phagocytic cells. Eventually, what will happen is that the infected cells are going to be surrounded by white blood cells, so that over time, there is going to be the formation of a hard structure that is called a tubercle. And that tubercle is very characteristic of tuberculosis. And that is, by the way, the reason why the disease is called tuberculosis, because the patients have tubercles in their respiratory tract, right? And eventually, the bacteria are able to multiply in those tubercles. We don't know the mechanism by which one goes from bacteria imprisoned in tubercle to this tubercle breaking down, bacteria starting multiplying, and the lungs starting to fall apart. We do not know the mechanism by which this happens or what triggers that progression of the disease. That we don't know. So the tubercles actually they are called granuloma. Okay, this granuloma are very characteristic of tuberculosis. What else should I tell you? Mycobacterium tuberculosis is able to survive in our phagocytic cells. I'm not going to bug you with the details, but I just want you to know that. Other things that I need to mention, it's that, tuberculosis can actually is more active in immunodepressed patients. Now, typically, over time, Mycobacterium tuberculosis is going to break away from the tubercles and spread to other parts of the body, including the lungs, including the kidney, the bones, which can actually cause tuberculosis to become systemic. It sounds crazy, but that is totally possible, right? And at that point, when one has a bone tuberculosis, that's pretty much a bad news. Regardless, it's already a bad news to be a lung tuberculosis, right? So tuberculosis can be diagnosed with a PPD test, and eventually one has to do an X-ray. Okay, this is a reaction to a PPD test. Okay, depending of the diameter here, we're going to say that one is positive to the test or negative. It just depends on the diameter. In terms of treatment, we already talked about this, but I'm still going to talk about this anyway. Because Mycobacterium tuberculosis is a slow grower, the treatment is also a long-term treatment. Now, that long-term treatment lasts at least 6 months. It goes from 6 months to 9 months for a sensitive form of tuberculosis. For resistant form of tuberculosis, the treatment can last up to 24 months, right? And when I say 24 months, I mean daily administration of the medication. Now, in a case of a sensitive form of tuberculosis, what is the treatment? Well, a combination of 4 drugs: rifampin, isoniazid, pyrazinamide, and ethambutol. These 4 drugs are used in combination for 2 months. Then, after that, you have isoniazid and rifampicin that are given for 4 to 7 other months to actually make sure that the organism is cleared from any Mycobacterium tuberculosis. Now, it so happened that because mycobacteria can actually evolve, they can develop resistance to any of the drug. The most common resistance that we see is resistance to isoniazid and rifampicin or rifampin, right? These are the most common. And when we see a strain that is resistant to these 2 drugs, we say that we are dealing with a multi-drug resistant. And this multi-drug resistant strain are tough to treat. Because of that, at some point in the history of the fight against tuberculosis, there was the development of what we call directly observed therapy. Okay? That directly observed therapy, because it was not systematically well was not necessarily as successful as we wanted, we modified the protocol to make it directly observe therapy short course. Okay? That short course meant that to make sure that patients are going to take all their treatment and that the treatment is not dragging for a long time, which actually causes the resistance. I mean, the lack of compliance, right, among the patients. Well, physician thought, I mean, the health system thought, okay, well, we're going to give a short course treatment, right? And that short course treatment, it's a huge amount of drugs in a short period of time to make sure that this organism is destroyed, and then whatever happens after, we know that we've done our very best. Okay. So eventually, because of the development of drug resistance, we have some cases of even the development of what we call extensive drug resistance. And this extensive drug resistance are resistant to drugs that are second line drugs. Now, let me tell you about, I did not mention earlier that isoniazid, rifampicin, pyrozinamide, and ethambutol are all four first line drugs, which means these are first intention drugs, right? However, you have second line drugs. These second line drugs are very good. However, they have strong side effects, right? So we only use them when the first line drugs are not doing their job or when there is cases of multi-drug resistant. And that we are going to treat this MDR TB strains. However, we do see a resistance among the drugs that are second line drugs, which actually leads to strains of TB that are extensively drug resistant tuberculosis, right? XDR TB, which is actually a very bad news and quite frankly a death sentence. All right. So how do we prevent the spread of tuberculosis or even the development of tuberculosis? Well, in the United States, there is not really a way. Let me digress. There is no vaccine against tuberculosis in the United States. In the rest of the world, there are some parts of the world where there is a vaccine against tuberculosis, right? But in the United States, there is no vaccine against tuberculosis. So one has to go by all measures of prevention, so hygiene, screening, treatment, right? But there is no vaccine against TB that is actually used in the United States. In other parts of the world, yes, but not in the United States. What else can I tell you? So when you do a PPD test, in general, if you are positive, they're going to have to do an X-ray, okay, to make sure that you don't have the disease. If the X-ray turned negative while you are still positive to the PPD test, you're going to be given a treatment. Okay, so if you are a teacher has to take a PPD test before actually starting teaching. If you are in early childhood education, you have to take that the treatment. I mean, the PPD test. If you are positive, you have to take a treatment. If you work in a healthcare environment, same thing, right? So the vaccine that is used in the rest of the world is called BCG, Bacillus calmette and Guerin. Okay, this is a live attenuated vaccine. By the way, this vaccine was developed in at the university where I did my PhD. I mean, at the research institute where I did my PhD back in France. All right, so what else should I tell you? I think that's about what I want to tell you here about tuberculosis. So this slide right here, it's actually a slide to a summary slide. Take the time to go over it. I already talked about everything that you see here on the slide, but take the time to review the slide. I'm not going to go through it again. Okay? So this is where I am going to stop this conversation. And on Thursday, I'm going to resume our conversation here where we're going to talk about viral infections of the lower respiratory tract. All right? Thank you for your attention. Bye now.